I'm Shannon, and I'm a nurse here in the Neuro ICU at Christiana. I'm going to talk to you about the different roles that the nurse plays in the interdisciplinary approach to the early rehabilitation for stroke patients. I'm also going to present a case study that everyone else will follow up on. All right, so the RN spends most of the contact time with the patient, and just like Becky said earlier, we play the central role in the rehabilitation for these patients. Main roles that we do play are the ongoing patient assessments, acting as an advocate for the patient, collaborating and working with the multidisciplinary team to individualize the care and fit the patient needs, and coordinating between medical care and therapies, again, based off individual needs of the patient. So the first role that I'm going to discuss is the nurse as an advocate. Remember, time is brain, and this applies to all interventions done after a stroke. So the earlier the intervention, the better the outcome. That means consult necessary therapies in a timely fashion. This would ideally occur on admission when the RN is reviewing orders for the new stroke patient. If the nurse sees that there's a missing therapy order, that would be an opportunity to have a discussion with the team to find out if consults need to be put in at that point, again, on admission. Here at Christiana, we have a bedside swallow exam. That's part of the protocol, the order set for a patient with a stroke diagnosis. And this means that the nurse has to perform the bedside swallow exam on all stroke patients. In the case, if a patient does fail the swallow exam, then speech is automatically consulted as a result of the nurse just pushing the fail button on the protocol. So that helps get early interventions and speech involved early, and that way nutrition needs can be met and without delay. The same goes for mobility. In the Neuro ICU, if a patient gets IV TPA, they are on bleeding precautions for at least 24 hours. That should not stop them from getting up and getting out of bed. So you need to collaborate and communicate with the healthcare team and advocate for getting mobility in sooner rather than later. You don't have to wait 24 hours to get them out of the bed with the bleeding precautions. Again, earlier the better. The bedside nurse is also responsible for knowing patient individual needs based on the deficits that they've suffered from the stroke. All strokes are different, so the care plans always need to be individualized to fit the needs of a specific patient. So the next role I'm going to talk about is the nurse as a collaborator. Because of the amount of time we spend with the patient, we have the most interactions with members of the interdisciplinary team. So one very important collaboration that for the stroke patient is communication between nurses, and that's from floor to floor, unit to unit, and also, from shift reports that you have. So our stroke patients have potential to experience many changes through the course of their hospitalization. So that also means their therapy needs can change as well. So it is important to discuss what mobility needs, OT needs, and speech needs that an individual requires. And this can just be as simple as saying, how does the patient transfer? What type of diet is the patient on? How do they perform their ADLs, and what assistance do they need? But that needs to be communicated just as important as what their blood pressure has been running. Another point to discuss between nurses are any barriers during hospitalization that would affect therapies from being completed. The nurse is also responsible for the collaboration and communication with the physicians regarding changes in the care plan and the needs of the stroke patient. Often the nature of the neurological injury allows for changes to happen suddenly, unexpectedly, and often frequently. This requires frequent communication and reevaluation between the team on the plan of care. So new consultations for therapies might be ordered, then they might be discontinued, then a couple days later they might be ordered again, and this can happen multiple times over the course, which we will learn in the case study. In the Neuro ICU, our multidisciplinary rounds include bedside nurse, providers, and are attending respiratory therapy and pharmacists. The nurse presents on the patient's assessment, and then it's followed by the provider presenting on the plan of care for the patient. This is an opportunity to cross the T's and dot the I's to make sure that necessary therapies are provided as well. So discussing therapy needs on every patient is actually part of the rounding tool that we use in the Neuro ICU to ensure, again, all those T's are crossed and those I's are dotted. So another big part of the collaboration role is between nurse and therapist. So changes in patient conditions need to be communicated because that can delay their opportunity to participate in therapies. The bedside nurse we are the eyes and the ears of these patients. So we know when these changes are happening. The therapist might come in and not realize that the patient just got intubated overnight and won't be able to participate as they would, the day prior. So we do need to be communicating any changes. In addition, some therapies that were not consulted in the beginning of a patient's stay might need to be consulted midway through. If a patient comes in intubated and then, a few days later becomes extubated and needs a speech consult, at that point, that would need to be reevaluated. So this collaboration is an opportunity to clarify the use or schedule of ordered devices. So for example, if you're collaborating with OT, if the patient needs bunny boot or how the bunny boot, the foot drop boot should be applied appropriately on a time schedule. Also, any need for medications is a discussion and collaboration between therapist and nurse. So as the nurse, we act as the liaison. The therapists aren't able to participate in rounds as of now with our team. So if the therapist says, hey, this patient might benefit from something for, the contracted arm, and we could bring that to our healthcare team about maybe getting some baclofen ordered, that's what we are for. We're the liaison. We can, that's our responsibility in this role. Also, collaborating with them as far as pain medications. Will the patient perform better in his or her therapies if they're pre-treated with pain medication before doing that? If that's the case, you might say, hey, I'm going to give them some medication. Can you see another patient? Come back once that medication can take into effect. So again, that collaboration is key. And face-to-face communication between therapists and nurses is always appropriate. It's not often that we can sit down at a computer and scroll through progress notes on what the therapist did with our patient 2 days ago. So having that communication with the therapist really does make that easier for making sure everyone is on the same page. And ideally, the bedside nurse should be present for the therapies. This isn't always possible. We get busy, we have other patients, but ideally the bedside nurse should be present. That way we can see what therapists are doing and that we can do the same, practice the same way. The nurse and the therapist should also communicate when is the best time to provide these therapies, and if possible, couple them together. Often in the neuro ICU, the therapists come in waves. So we'll see, PT and OT traveling together, and if they're not in the room together with the patient, they're going in right after each other, which is good. Because it's that more comprehensive approach. And again, if the RN can be, he or she should be available to help and be present for that. So with complex stroke patients, there are several disciplines involved in the care requiring thoughtful and individualized planning and scheduling to ensure maximum benefit for the patient. Our stroke population requires a lot of coordination and care, because there's often a lot of procedures involved, like CAT scans, MRIs, Doppler studies, and sometimes they're going to interventional radiology once, twice a day. So these patients are very busy, and on top of that, we're doing hourly neuro exams, and they're really not getting any sleep as well. So we do want to coordinate the care to try to include everything, because therapies are equally as important as an MRI. They are we want them to get the most benefit, because that's essential for their recovery. So on to the case study. We're going to talk about a patient, initials SR, is a 68-year-old African-American male with a past medical history significant for hypertension, hyperlipidemia, and dementia, who presented to the emergency department with an acute onset of dizziness and coffee ground vomiting after awakening from sleep. He was a stroke alert on arrival with an initial NIH of 5. The CAT scan was negative for a hemorrhage, but was suspicious for posterior circulation stroke. He did not receive IV TPA because of the high risk of GI bleed. He was sent to our stroke step-down unit on 6D for further stroke workup. So after assessing this patient on admission to the hospital, the nurse next begins his or her work as a patient advocate. The patient should have therapies consulted upon admission. This can include PT for his dizziness and ambulatory dysfunction, as well as OT. A bedside swallow assessment would be completed by the RN on the STAR unit, and necessary speech consults can be placed. So on admission, the patient's vital signs were stable and within ordered parameters for ischemic stroke guidelines. Mr. R initially showed no barriers to participating in therapies. And as the collaborator, the nurse can speak to the therapist to discuss findings in the exam, for example, his vertigo. In terms of coordination of care, the RN must consider that the patient is going to require more imaging as part of the stroke workup. And this should be consulted with early therapies. So on the second day of hospitalization, SR is transferred to the neuro ICU due to recurrent vomiting with respiratory distress. Patient also presents to the neuro ICU with a slight right facial droop and slight right-sided weakness with a motor strength 4 out of 5. His NIH on transfer is a 9. The chest x-ray is suspicious for aspiration, and shortly after transfer, he required intubation due to his deteriorating respiratory status and compromised airway. So the bedside nurse does continue frequent neuro assessments of Mr. R and develops an individualized plan of care. So once the patient's transferred to the neuro ICU, he is more unstable from an airway standpoint. He is not appropriate candidate for therapies on the initial assessment. Once he's intubated, he was started on a continuous infusion of fentanyl and propofol, and the bedside nurse is responsible for titrating these medications to determine or to achieve an ordered RAS goal, which usually is about 0 to -1, and then determining can the patient still participate in therapies with this RAS goal. And in his case, speech would no longer be necessary because he has the ET tube in place. So until he could participate in speech, it would not be necessary. So that could get discontinued. The nurses do need to collaborate when transferring the patient from unit to unit within the hospital, in this case from the STAR to the ICU. Collaboration between the providers and the RN is also appropriate to ensure new ICU needs are met and a plan of care is in place. And of course, communication between the RN and therapists are necessary due to the patient's change in condition. So by day 2, the patient, he's still intubated, but he's able to follow simple commands and nod his head yes or no appropriately. His MRI did confirm a completed infarct in the right lateral medulla, and his EGD is negative for an upper GI bleed. The patient did require 1 unit of packed red blood cells but because of his hemoglobin 6.4. He was successfully extubated on ICU day 2, and because he was still dysarthric, he required a Dobhoff for feeding and meds and was on strict NPO. He was transferred out of the ICU on day 5. While on the STAR unit, he continued to have periods of waxing and waning, as we say in neuro world, and agitation, and he was pulling at his peg tube as well. He was in restraints and also a high fall risk. I got my papers all out of order here. Sorry, guys. Hold. Sorry, guys. I got my paper all out of order there. Oh, well. Sorry, guys. Okay, so he did continue to wax and wane, and on day 18, he required reintubation and was transferred back to the neuro ICU for bronchoscopy with the removal of a mucus plug. He was extubated the following day, sent back to the STAR unit, and still continued to have the waxing and waning of the neuro assessments. And he did require intermittent doses of medication for agitation, also bed rest, also restraints, all factors that was playing into the therapies not being able to be completed or delayed. So he was discharged to an acute rehab on hospital day 25. So I do think that is the end. Yep. And then Phil Doucette is going to talk from the speech pathologist approach for this case study.